for joining. Thank you for joining. We were going to discuss today outpatient infectious disease pearls. We'll keep it interactive, and you guys ask any questions, and we'll go through different topic by topic.
Yeah, hi, I'm Dr. Horn.
Dr. V.
And we'll go through. So we've been getting questions. We wanted to have one of these discussions where we essentially go through a lot of the random questions that we get asked day to day. And so I think that's good. Some of these, are very quick questions, but they answer things that I think can be very helpful. So this first slide, it just says 70% of antibiotic prescriptions are likely unnecessary. And really when they look at it, they'll look at, was the antibiotic, was it needed? And was it given in the proper dose? Was it given for the right reason? And some of these statistics, they show that a lot of antibiotics are unnecessary. And then in the outpatient setting is really where I think most of the antibiotics that are unnecessary are given.
Yeah. I want to kind of give you some stats. They usually put out a report for outpatient antibiotic and antibiotic use. And the last report I saw was published in 2018, but 2016 data, where they estimated we're using about 47 million antibiotic courses each year that are prescribed. And out of that, 30% of prescription are unnecessary. Antibiotic prescribing nationally, however, has gone down 5%, which is great, from 2011 to 2016. But we still have a long way to go and a lot of opportunities to do to decrease antibiotic prescribing. And this is kind of interesting if you guys look at it. In 2016, 270 million antibiotic prescriptions were written in the United States. That's enough antibiotic courses for 5 out of every 6 Americans. So that is a lot of antibiotics being prescribed. Prescribing rates vary by states. So there's a really nice graph on the next that Dr. Horn can show.
This is community antibiotic prescriptions by state, and this was done by population. So it was looking at prescriptions per 1,000 people there. And you can see that, that some of the states have a lot of antibiotics that are being given, especially kind of in the South, and Nebraska as well. Nebraska has some large medical centers compared with the smaller population. At least that's kind of the reason I try to tell myself the reason is why it's so high.
They're capturing community, right? So they're also
right. They're leaving the hospital on antibiotics. That's that's my reasoning there.
So they're capturing like clinics, outpatient clinics, urgent cares, ERs. We are using a lot of antibiotics that might not be good.
Right. Yeah, and really, it's if we can give, if the patient doesn't need an antibiotic, hopefully we can, prevent that from them from getting an antibiotic or getting it right only when needed. But it's something that takes a lot of effort. It takes a lot of energy to kind of talk to the patients and kind of persuade them that they don't need an antibiotic at this time.
I kind of really like this graph a lot. It kind of tells us like percent of visit for respiratory illness and unnecessary antibiotic prescription. So, in the outpatient setting, the antibiotic prescription a lot of times happen for like bronchitis or ear infection. So this is kind of focusing on respiratory bronchitis-like picture. And where do we prescribe unnecessary antibiotic? Number one, 46% of unnecessary therapy is being given in urgent care, 25% emergency department, 17% in medical offices, and then 14% in retail health clinics. So we have a lot of opportunity in all the different areas.
I think respiratory illnesses, I think that's number one as far as unnecessary.
Exactly.
Right? So it's difficult because the patient comes in and takes more time to discuss with them and not give them. It's harder not to give an antibiotic than to give one.
So I really like this study. This was just published in 2019, where they looked at about 1,000 patients in an ER, and they looked at who received appropriate versus unnecessary antibiotic. Just in the study itself, they found that they looked at, out of the 1,000 people, they looked at 333 patients. So 32% of them assessed as inappropriate for antimicrobial use. So that's a big chunk, a lot of antibiotic we're prescribing that might not have been needed. And then another interesting thing is, this was kind of new to me, it's more inappropriate antibiotic were prescribed for adults versus children. So more in adults than in children. So that's another important takeaway from this.
And there are also studies that look at why they're getting an antibiotic, and they'll ask the prescriber, they'll say, why are you giving them an antibiotic? And one of the answers is that they have this perception that the patient wants an antibiotic. They'll say, well, that's what the patient wants. But when they actually poll patients, sometimes the number one thing is the patient will say, I wanted to find out what was wrong. And so it's not always, I need an antibiotic. It's more of, but there's a perception by the clinician that the patient wants an antibiotic, I'll give him an antibiotic. And that's, it may help your patient satisfaction scores, right? But I won't get into that. But it may not help the patient. Right?
Yeah, I think it's slowly changing our culture where we have to have good conversation with our patients and, kind of when to need antibiotic, when not. And it's hard, but it's slow and steady, and we could get there.
Oh, yeah. And it's not just for education for the medical people in medicine, it's also education for the, like you're saying, like the general population.
Exactly.
And here's appropriate antibiotics in the emergency department. And so they're looking at appropriateness, and they'll have treatment of the abdominal, CNS, dental, and kind of which different organ system.
What was interesting in the study is like they look at appropriate and inappropriate and like different, organ system, like you were saying. But if you go to the inappropriate, the second category right here, for ear, nose, and throat, 55% of the time was inappropriate. Dental, 61% of the time. So there's a lot of inappropriate. Respiratory, 32% of the time. The N is small, but still it just kind of displays the importance about how many times all these different categories we're prescribing unnecessary.
All right, and I think that sometimes it's hard to decide when you see the patient whether they should get it or not, but 55% of the time that's a pretty
big. Yeah.
This is where we get our information from. So Infectious Disease Society of America guidelines. So if you're wondering, where we get our information, if you go to the Infectious Disease Society of America and look at their guidelines, it will have, it'll have guidelines on really all the different organ systems and what the recommendations are and the level of evidence.
Yeah, and it's free, so anybody can go get guidelines on this. And I love sharing this, both of us do, so that people can know where to go.
Right, because if you didn't know about this, then it's hard to kind of go find the answer. Finding answers for things can be kind of difficult, but that's where we get our information from. And what is the break point? So I think this is a good topic because this is a common question that we get. And so, sometimes people will call us and they'll say, I have this patient and he's growing E. coli, and they'll go through all the MICs of everything. They'll say the MIC to, this antibiotic is this one is this one is this. And then they'll say, so I went with the one with the lowest MIC. And so I think this is a good topic because really when you're choosing an antibiotic, if it says, you want to think about what you want to use, and which will generally be a beta-lactam if possible, and then see if it says susceptible or not. And so, and then I would kind of go from there and then, see if there's any contraindication, if they have an allergy or if they have some other reason they can't take it. But the main thing here is not to go with the lowest MIC, it's to go with the correct antibiotic for that patient. And if it says susceptible, then that's okay.
Yeah, I loved your explanation. And just, when you get the MIC in the lab, they're not comparing Bactrim to Doxy, right? They're just looking at what is the break point for Doxy itself for this bacteria, and what is the break point for Bactrim itself for this. The cutoff is for each bacteria and the antibiotic, not to compare each other. So then, just because Bactrim has MIC of 2 and Doxy have MIC of 4, but they're both equally effective if it says S and it's susceptible. So yeah, that's where, not to fall into that lowest number trap.
Right, and this is a question on our infectious disease boards. They'll show us a susceptibility report, and then they'll say, which one do you want to use? And they want to make sure people know you can't compare one MIC to another MIC because they're specific for that antibiotic. Yeah. And the lowest, so this is the takeaway point. The lowest number does not always mean the most potent drug. And so, you know, there are instances where it's important to look at the number, but as far as comparing one drug to another, that's not the way to do it. It says pick the ideal antibiotic in that situation. And if it's susceptible, consider it for that patient. Is it appropriate? Is that what you want to give? And kind of the renal function, liver function, these kind of things. But I think this is a really important point where you know, not comparing MICs, just which drug do you want to use? Is there an S next to it? And then go from there.
So then I kind of want to share this example with you guys. So like this, in this case, you have a 55-year-old patient with urgency, frequency, pain with urination, and they're coming to the clinic, right? So then you get a culture, you already have a culture, and now you have the susceptibility here. So if you look at all the numbers, you have lots of S's and R's. But for me, if I look at this patient in the clinic, if it's just like cystitis and they're doing okay otherwise, now I'm going to look at oral options. So my oral option is Augmentin. This has an S. And then I go down to here, nitrofurantoin has an S in this case, right? So then do I jump to an IV antibiotic where it's ertapenem, or can I use Augmentin or nitrofurantoin? So in a patient who has like cystitis, you know, a female, not a lot of complication, I might just go with nitrofurantoin for 3 days. And if you guys went by the MIC, nitrofurantoin has the higher MIC and Augmentin has the lower MIC. But as you see, I picked the one, even though it's higher MIC, it's still susceptible. So I think that's kind of the takeaway point for the patient, the scenario, what we should be using.
Yeah, and you know, this susceptibility report shows a lot of antibiotics, and you know, most labs will actually suppress the antibiotics, the later antibiotics, like kind of later line antibiotics like carbapenems or glycosides or something like that. And so if the patient has allergies to some of the first line drugs, sometimes we'll get called and they'll say, oh, they didn't test carbapenems. And sometimes what happens is that they did test it, they're just not showing it to you. They don't want you to use it, so they're not showing it to you.
So, but if it's really urgent, or if it's really needed, you could always call the lab and they could tell you what the susceptibility is. They could unhide it for you.
Yeah, and that's if a patient has like penicillin allergies or they can't take some of the drugs that are shown, then we'll call the lab and ask, was anything else tested? And then they may have to confess that they're hiding some from you and they didn't want you to use the fluoroquinolones.
But in my mind, though, I think it's a good way to do antibiotic stewardship.
Yes, no, no. So I don't want to make it sound like they shouldn't be.
Yeah.
So it's good because oftentimes we'll also get a call. So similar question to that MIC question, we'll say this has the lowest MIC. People will say, oh, ertapenem, that's once daily, so I'm going to use ertapenem. Or, oh, linezolid is susceptible. That's a PO option. And so, you know, that's the reason that they hide them, is because really what we don't want to use up linezolid and we don't want to use ertapenem if we don't have to. And that patient will thank you for it, right? So if there's a beta-lactam, if there's one of the first line agents, that would be the recommendation. Oh, and then bites are a good topic as well. So this is a frequent question that we get.
Yeah, so like in the urgent care, ER, even clinic setting, I think clinicians see a lot of bites. Cat bite, dog bite, human bites. So for us, it's actually board questions too. So cat carries this bacteria called Pasteurella. Dogs also can have Pasteurella and the other bacteria called Capnocytophaga. And then humans got lots of bad bacteria, but one of them is called Echinella. So all these bacteria, if you have a bite, we always get asked, what is the first choice antibiotic?
Yeah, and Augmentin is really the drug of choice for bites. And when I say the drug of choice, what I mean is that, so if you have a cat bite or a dog bite, now a cat bite would be most likely to get infected. And this is something I ask our residents and fellows, so why is the cat bite more likely to get infected than a dog bite? And the answer is that they have kind of needle-like teeth, and the needle-like teeth can go deep, and it can go several layers deep and put the bacteria deep into the person. So if a patient comes in with a cat bite, even if it doesn't look infected, we would recommend giving Augmentin. Now, dogs have kind of blunt teeth, and they do more ripping and tearing, and the dog bites don't get infected as often. Now, if it's a bad bite, some of the bites can be very bad. Then it's okay to give antibiotics, but but it's not as likely as a cat bite. A cat bite, we'd say definitely give antibiotics for. And a human bite as well, there's either it's from when someone punches someone and then they have cuts from their teeth on their hand, or little kids bite each other in daycare. Yeah. But if it doesn't look infected, so our teeth are kind of blunt, right? So they don't go deep. So if it doesn't look infected, those you can often just watch and give antibiotics if needed, right?
I learned this from my children.
They
got bit, but the pediatrician was like, it was mild. It wasn't, the skin was not broken. Yeah. But any bites, the skin is broken. Ideally, you should give like 3 to 5 days of like prophylactic antibiotics, especially with cats, like Dr. Horn was saying. They're so deep, they go deep in. So Augmentin is the drug of choice, and sometimes what we get called is like, I gave Augmentin for this patient, it's swelling and it's red, it's not getting better, right? It's not because the antibiotic is not working, it's that now you have a deep infection. So what you need to do is get an MRI or CT of the hand when those type of scenarios pop up. It's like a hand is swollen or the bite side is swollen, and usually what happens is they have a deep abscess, they have tendon infection or bone infection. So it's not the Augmentin is not the right choice. It's just that it's a deep infection and you just need to investigate and do more treatment.
Yes, if they're going to be outpatient, Augmentin is the best choice. If they're inpatient, you can give Unison or Sinus or something like that. Yeah. But yeah, and when you read about it, it'll say something like if they're bitten like in a sensitive area or something, and you have to look and go, oh, their hand, that's kind of important. Yeah. I think we should give them some antibiotics. Yeah. But one of the keys here is that, so Augmentin is first line, but not Clinda. So a lot of people will give clindamycin. And if you look it up in Sanford, or Johns Hopkins Guide is what I use, the app that I use, it'll say clindamycin, no. Yes. And so every once in a while you'll see in the news, someone was bitten and they went to urgent care or ER, and they got clindamycin, and then it continued to get worse. And this is something we actually see kind of frequently. Yeah. It continues to get worse, and then they come in, and I think people are thinking, oh, anaerobes, I want to give Clinda, but Augmentin covers anaerobes as well.
So Clinda doesn't really cover your Capnocytophaga, Pasteurella, or Echinella. It'll cover anaerobes, but it's not going to cover the main bugs. We actually had a patient who was like 30-something-year-old, had a cat bite, and they were given Keflex in the ER. This patient became very septic and needed ICU stay. So again, second-generation cephalosporin is another mistake. So Augmentin outpatient, Unison, Zosyn inpatient, and then things are not getting better, you could add an MRSA coverage too. But then imaging is important if things, you're admitting and it's swollen.
Oh yeah, if they come in, we recommend if there's anything to swab, getting a swab if it's bad, right? Well, actually, even if it's not bad,
if it's draining,
but for sure, if there's something to swab, you could swab it and give, oftentimes see a hand surgeon, and if it's really bad, MRI, and But yeah, no, this is a good topic.
And then the next topic is C. diff. We see a lot of C. diffs in the community, not just in the hospital. So what do we do when we see a patient with C. diff in the ER or clinic? If they're making sure their fluid is replaced, electrolytes are appropriate. But another thing that we need to pay attention to is, are they on a PPI, acid suppression, right? When you're giving C. diff medication and if they're on acid suppression, it's not going to work well. These spores don't get killed and they persist longer. So when you have a patient with C. difficile infection, it's really important to check, are they on a PPI and stopping the PPI until it gets better. And then if they're on an antibiotic at the same time, somebody else started an antibiotic, let's stop it if it's not needed, so we don't put pressure on the C. diff to get worse. Would you agree with those?
Oh yeah, this is great. This is, for all patients with C. diff, these are things you need to think about. And the next slide, we have the initial treatment. So this is, it has the clinical definition of non-severe versus severe versus fulminant. And then, how to define the supportive clinical data is how to define those. And then the treatment recommendation. And so we want to just highlight that the first line treatments are now vancomycin, fidaxomicin, and really metronidazole. This shows up kind of as an alternate. Is an alternative if you can't give vancomycin or fidaxomicin for some reason.
So if you're in an area where you cannot, for some reason, get vanco, fidaxomicin for initial episode, you can't use Flagyl, metronidazole. Unfortunately, just for you guys to know, metronidazole is over 50% resistant to C. So it's a backup drug. It's not our main drug anymore. And I'm still seeing patients in the outpatient setting who are getting metronidazole as their primary treatment, and that should not be the case because there's a lot of failures. Recently there were some GI guidelines update too on C. diff. It just came out in 2021. It's pretty much aligns with the 2018 IDSA guidelines.
And so we know that fidaxomicin is very expensive, and that's one of the reasons that it can have kind of reasons why people don't want to give fidaxomicin. And here it's vancomycin or fidaxomicin. In the future that may change. There are actually 2 new drugs that are being considered to come out, so that may change things. But just know as one of the main things here that metronidazole, not one of the first line.
And when you have recurrent C. diff, you could do prolonged vancomycin taper. You could do, again, fidaxomicin. And then another thing to kind of consider is thinking about fecal transplant. A lot of places now you could get frozen stool. I know with the COVID infection, the frozen open biome who was providing, they were having some issues with supplies. So, but you can now do fecal transplant, NG, colonoscopy, sigmoidoscopy. They even have pills that you could swallow, but it's like 30 pills. So you have, it's a lot of pills to swallow in like 60 or 90 minutes. But there's a lot of options, and strongly consider stool transplant if a patient has fulminant C. diff, they're having recurrent C. diff, high risk patient, so that you could get good flora back into that colon.
And here, when we're talking about reoccurrences, I kind of think of recurrences as they're sick with diarrhea, they get treated, and while they're getting treated, let's say with vancomycin, PO vancomycin, they improve and they get better, and then they may be better for a week or 2, and then all of a sudden it comes back just like it did before. I would consider that to be a reoccurrence. Now, if someone is taking PO vancomycin or fidaxomicin and they don't get better at all, if they take it and they say, I took it for 10 days, but it never made a difference, and they continue having, and they come back in and they continue having diarrhea, I don't think of that so much as a recurrence. I think of it more of as a failure, right? So, and so, that's kind of if it improved and got better and then reoccurred, I think of that as a reoccurrence. And the reason I'm bringing this up is because sometimes we'll get calls in it. If a patient never got better on it, then it'd be important to kind of think of other things, right? So if they had positive C. diff in the stool, but it never made a difference if they were getting treated, then what are some other diagnoses it could be? If there are other things that to consider, because sometimes it's kind of anchoring, where if I'm seeing a patient and someone says this is C. diff, I need to kind of decide, is this C. diff? Could this be something else? But it's very easy to say, oh, this is C. diff, and not think about it anymore.
And also in those cases is when you can think about stool transplant.
Yeah. Oh, sure. Oh, for sure. Yeah. If you decide this is C. diff and it's not responding, what are my other options?
Exactly.
Oh, yeah.
And then I did want one more thing.
Oh, sure.
The new GI guidelines, we always talk about this, and we always do it in real life. Like, let's say I had an 80-year-old patient who had C. diff, like last month, and she comes in now with pneumonia, and she's going to get like Ceftonir for 7 days. I always put her on like, oral Vanco twice a day until she's done with the pneumonia treatment in 7 more days after that, so that she's protected and the C. diff doesn't come back. In 2018 guidelines, they didn't really recommend this at all, but in GI guidelines that came out recently, they're saying you can consider. So in patients with high risk for recurrence, you could consider giving Vanco twice a day until they're finished and like 7 days after.
Let's see, the diagnosis and treatment of adults with community-acquired pneumonia. So I think this is a good topic to discuss as well, because it's something we see so frequently. And CURB 65, many of you are familiar with this, but we wanted to touch on it just so it's, just to mention the importance of sending them to the right place. So CURB 65 is used for patients that you say this patient has a community-acquired pneumonia, and you're seeing them in the outpatient setting, and you're trying to figure out where should I admit them to. And they have this because some patients don't look so bad, and so some clinicians will look at him and go, I don't think he looks that bad. I think you can treat him as an outpatient. And another clinician might look at the same patient, same decisions, kind of be a robot kind of, and just say, here's our algorithm. I think they need to go here or there. And so with CURB 65, it's used very frequently because you don't really need any labs. The only lab you would need is a BUN, but you can make up your mind of where to send them without the BUN.
I really like this slide, following up on you, to see the mortality if you place them in the wrong area. So like, if somebody who should be in the ICU, if they come to it's really high mortality. So I think this is a really good tool to continue to use. And if it's low numbers, then you could treat them as outpatient.
Yeah, and they do studies, because you might say, well, why is it important that I put them in the right place? And if they move, so if you put them on a medicine floor and they should be ICU, if you put them on a medicine floor and they change to ICU status within the first 24 to 48 hours, then they do a review and they say, oh, that patient should have been in the ICU from the start. And mortality is higher. They're more likely to die if they were put on the medicine floor when they should have been put in the ICU. And so that's why we just wanted to show this CURB 65 scores.
This is a table from the new community-acquired guidelines. So, I didn't go into antimicrobials when you get admitted to the hospital. This is just for when you're outpatient, right? So what antibiotics do we use? So the most common bacteria that we worry about for the most part is, strep pneumo, atypical, sometimes like mycoplasma and things like that. So no comorbidities, no risk for MRSA, no Pseudomonas concern. You could do amoxicillin, doxycycline, okay? But you guys see how macrolide, which is azithromycin, if your local antibiogram for pneumococcal pneumonia resistant is less than 25, then you could use it. For example, we're in Omaha, the antibiogram, strep pneumo is over 50% resistant to azithromycin. So not a good choice. So in the community setting, ER, urgent care, clinic, we should not be using azithromycin for community-acquired pneumonia because it's over 50% resistant. So you could do amoxicillin, and then if there's comorbidities, you could do augmentin or cephalosporin, right? So third generation cephalosporin like Ceftonir, which is cheap, and it's third generation, it's oral, so you could do that. Plus, so when it's comorbidities, you do augmentin or cephalosporin with atypical therapy like macrolide, cover your mycoplasma or Legionella, right? So doxy or macrolide can do the atypical coverage. You can do fluoroquinolone in the outpatient setting. It'll cover both strep pneumo and your atypical. But there's so much badness with fluoroquinolone.
Yeah, generally, if there's any better choice,
yes.
If there's any option that's better than fluoroquinolone, I think cephalosporins would be a good way to do it.
Yeah, so cephalosporins is great, high risk comorbidity, added atypical, but try to avoid the fluoroquinolone as much as we can so we can really reduce C. diff.
And here are the most common etiologies of community-acquired pneumonia. So if you look at the, let's see if I can get a pointer. So if you look at the patient type, and let's see, outpatient, so it's strep pneumo, inpatient, strep pneumo, inpatient ICU, strep pneumo. So whatever you give, you want to make sure that you're covering strep pneumo very well, right? So you want to make sure that you're getting the number one thing. And so whatever you choose, you just want to make sure you're covering that well. And but those, and especially looking at your own antibiogram for your own hospital.
Take home point for here would be if we are still using azithromycin as a community, I think there needs to be some discussion changing up that practice.
Yeah, and this is looking at outpatient, and all of these patients, this is community-acquired pneumonia. And so it's kind of, if they were treated as an outpatient, these are the most likely things. So looking at that curve 65, these patients weren't too sick. This is inpatient, these were more sick, and then these were the most sick. And you can see that Staph aureus shows up here for the inpatients that are the most sick. But it's really important, we try to stress this, that strep pneumo, they can be not that sick, but it can make people extremely sick, and they can die very quickly from strep pneumo. So that's just something that we just wanted to make sure that everyone was aware of. Sometimes people will think, oh, you can't get too sick with strep pneumo. Usually those are our students and residents that we try to, when they're rotating with us, we try to say, strep pneumo can be very bad.
This nice picture from CDC again. Most patients need 5 days of antibiotic therapy for community-acquired pneumonia, and that's what our guideline says right now. However, 70% of adult patients hospitalized for community-acquired pneumonia receive 10 days of treatment. And this 10-day practice, 7 to 10-day practice, is also very common in the outpatient setting too. So I think it's going to be, here's where we are using unnecessary antibiotic for a prolonged period of time. So really important if we could stick with that 5-day treatment if we can for community-acquired pneumonia.
And a lot of this, I think it comes from people saying, oh, I know 5 days is what we should do. This patient was very sick though. Yeah. But even in the studies of patients in the ICU, shorter is better. Shorter is better. And so 5 days is just fine, even if they're very, very sick. You don't have to give extended durations. You can stick to the because these durations are for people that are very sick as well. And what is the optimal treatment for acute uncomplicated cystitis?
Yeah, so if you have a patient, we see a lot of UTIs in an outpatient setting. So for the most part, 3 to 5 days is plenty. If you're using nitrofurantoin, maybe 5 days, Bactrim or ceftonir, 3 days. Looking at your antibiogram, most common cause of UTI, E. coli, so kind of knowing what is your susceptibility to E. coli, and then kind of treating as you can. So kind of wanted to give you guys a duration for cystitis. And one dose treatment for 3-day regimen preferred has good outcomes. Minimizes the number of antibiotic use. So 3 days is good. And then this we get asked about a duration. So, if you have UTI, recurring UTI, for the most part, 3 days, unless it's like really complicated, 7 days. And pylo, depending on the antibiotics, 10 to 14 days.
Yeah, and I'd recommend not giving something for prophylaxis. So even if patients have recurrent urinary tract infections, I just saw one this weekend where they were getting indefinite Keflex, and really, if that worked, that might be an option, but it really doesn't seem to work very well. So if possible, then I'd recommend seeing ID if you have that option, or but treating them as they come up. It's hard to do, but it's if possible, that's the way to do it.
Yeah, I always tell for older patients in clinic, they get referred to us for UTI, but they have no symptoms, and somebody just checked the urine, and now they have they get urine keep on getting culture, and they got so many antibiotics for this, and then it's so resistant, and they get referred to us. But we should have never checked it in the first place. So we're going to get into here's a little picture, but we're going to get into duration. We just kind of talked about, but when not to check.
Not indicated.
Indicated,
chronic
right?
urinary catheter. Right. So a lot of patients get admitted to the hospital and they're not really sure what they have, so they check the urine, and if it grows, that's what gets blamed.
Yeah.
And so I'm always kind of suspicious if they say, you know, they have this plus a urinary tract infection, right? So they'll say they have a pneumonia plus a urinary tract infection, and usually it's, or they have a broken arm plus or a broken hip, or they had a fall plus a urinary tract. It's kind of it's kind of suspicious to me.
Yeah. If they don't have any symptoms, we need to stay away from the urine, because you're going to grow something, and our poor elderly patients, they get treated over and over again. So here is the recommendation when we should treat asymptomatic bacteria. In our world, there's only 3 things. Pregnancy, because mom can have early labor, so miscarriage. So pregnancy, if they have asymptomatic bacteria, we need to treat. Get a kidney transplant within the first 6 months, you should treat. And the third one is when you're doing urological procedures, cystoscopy and things like that, where they're going in and manipulating the urinary system. You could have transient bacteria leaking and get bacteremia. So that is okay to treat.
And that's just a 1 dose before the procedure.
Exactly.
Right? And so it's not to sterilize the bladder, it's just to keep it out of the blood.
So give 1 dose exactly before the procedure. Renal and pregnancy, treat them for like 7 days. But otherwise, we should not be checking urines if people don't have symptoms.
And then the practice guidelines for the diagnosis and management of soft tissue infections. And so I think this is a good chart. I think this really sums up a lot of the information that when it comes to skin and soft tissue infections. This isn't perfect, but it's a really good way to organize it kind of and think about it in your head about when I should be giving these antibiotics or those antibiotics. And at the top, so it says management of skin and soft tissue infections, and then it's kind of broken up into 2 things here. On the right, you have pus, you have purulent, and on the left, you have no pus. So is there pus or no pus? And if there's pus, like on the right here, you'll think about Staph aureus or staph infections. And if it's mild, you do an incision and drainage. So if mild, if they have an abscess there, if it's, I think the studies usually say less than about 3 to 5 centimeters. So if it's about less than about an 1.5 inches or an inch abscess, you can just IND it. You can just essentially allow it to drain and you're good. And you don't even need antibiotics, really.
You don't. Recently, there were some studies that say even if it's small, it might be okay to give a short course of antibiotics, especially for Staph aureus. It will prevent recurrence, is what they're.
Oh, okay. So IND, and then moderate is incision and drainage and culture and susceptibilities, empiric treatment, Bactrim or doxycycline, and those have very good, they work very well in our antibiograms. Here, I think it's about
over 90%.
Yeah, I think 95%, not or more. Yeah. And so doxy or Bactrim, good plan. And then if it's defined as MRSA, you can give Bactrim. MSSA, you can give dicloxacillin or cephalexin. And if it's severe, you think vancomycin, daptomycin, you give something IV. And then MRSA, you can give the same, or if it's MSSA, you can give nafcillin, cefazolin, or clindamycin. And this is important here because sometimes people will give clindamycin thinking that they're covering MRSA. And on our antibiograms here, it only covers MRSA about 50% of the time. And so it's okay to give clindamycin if you know it's susceptible, if you have a susceptibility report. But just know that, and it's okay to give clindamycin if they have allergies and things, just know that you're not covering MRSA, or you're probably not covering MRSA.
Yeah, we have a good question. What would you suggest for patients that have severe dementia and cannot describe symptoms? I think that's my providers have a hard time treating because concerned UTI turn into urine sepsis. No, that's a good question. I would say when we're seeing patients elderly with dementia, right? Is there other markers that we are worried about for infection? Do they have fevers? Leukocytosis. Are they hypotensive? Like other signs? Because if we check our urine in a clinic, our genital area is full of bacteria, and it's normal and it's okay. And as we get older, a lot of our bladders get colonized with bacteria. So if you check it, you will find something. and then you're going to treat. So I think it's going to be really important, like are they dehydrated or something else is going on with them? Then get a urine and treat for them, because our elderly patients, they just get repeated antibiotic and then, C. diff and, really, really resistant organism, then you need IV therapy. So I think that's kind of, you kind of have to have that balance.
Yeah, and this is a problem because a lot of patients, they have dementia, and if they get confused, patients, especially in nursing homes, they just get antibiotics for confusion. But I think that's a good point with rehydrating them, because it seems like they get admitted to the hospital, rehydrated, and they do much better.
The recent UTI guidelines actually suggest that when patients get admitted, come into the hospital settings and stuff, rehydrate and wait for like 24 to 48 hours and see other things before blaming the urine. So I think, having other things in mind for our elderly patients is going to be important.
Oh yeah, so if they don't have a fever or leukocytosis, most cases it'd be okay to wait and give them, rehydrate them and see how they're doing and kind of follow them. But that's kind of a tough situation. And what are your opinions on the use of Dalbavancin in the ER setting for skin and soft tissue to prevent admission to the hospital?
Yeah, so I think that's a really good question. So if this is going to be a patient that you are going to admit to the hospital, but you want to keep them away from the hospital, I think you could do Dalbavancin or Ortavancin. But when you do these long one-time infusion and long follow-up, it's going to be really important to follow these patients up to see, is it getting better? So I think that'll be the key. If you give this drugs in an inpatient setting, it won't be covered, so you will eat the cost. But in the outpatient setting, it's covered under insurance, so I think it's a good option in the outpatient setting.
Oh yeah, and those are, we have criteria, I think, here about which patients meet criteria for it. So if there's a good, and the question would be, is there a reason they can't take the normal pills, or do you not trust them? Or so usually people talk about, patients that are using drugs like methamphetamines or something, and they don't trust them if they gave them, or they don't trust them to pick up the prescriptions. If there's an option like in this chart where you can give them antibiotics and you trust them to take it, then you could do that. If you don't trust them to take it and you think that they're unreliable, you'll never see them again. That's kind of where I think of Dalbavancin.
Yeah.
What do you think of that?
I think, some of the homeless patients and things like that, I think it's okay to do, but having a follow-up plan still is going to be important just to make sure it's getting better.
Oh, follow-up is key, making sure they're improving and doing better. And so if they either won't be admitted, or some of them refuse to be admitted and they say they're going to leave, then and you don't want to put a line in someone if you don't trust them with if they're a current user. But that's kind of when I think about using Dalbavancin. And then, so we talked about pus, and then no pus. This is, you're thinking strep. So most cellulitis, if there's no pus, are going to be strep. So about 80% of the time or so, they'll say, if there's no pus and there's a cellulitis, think strep. If there's pus, then the most likely thing is going to be Staph aureus, and its most likely thing is MRSA. So it's important to know that with just a straight cellulitis with no pus, no abscesses, that you can give penicillin, you can give cephalosporins like Keflex, like cephalexin. Moderate, then here it has IV. So milder PO, moderate IV, and then severe, you're thinking necrotizing fasciitis, which is usually pain out of proportion, and it is very, very bad, and you need surgery to see that patient.
Most of the cases in the outpatient setting, you're going to fall into the mild area. Yeah. So just knowing what oral antibiotics you can use is going to be key. So if you go to the next, Dr. Horner already talked about this. So what covers, especially MRSA, is going to be important. So a lot of times we see clindamycin being used, and it's over 50% resistant. So unless you know the susceptibility, and then you could use it. Clinda causes a lot of C. diff too. So, like Dr. Horn said earlier, Bactrim and Doxy over 95% susceptibility. So that could be your go-to. And linezolid, if you really have to, I don't really like it, but if you really have to, you have another option there as well.
And then we're moving on to ear infections. So we're hitting a lot of the outpatient antibiotics that are being used, and do they need to be used, and what is best. So there are different types of ear infections. Middle ear infections, you have acute otitis media of the middle ear, and causes strep pneumo, Haemophilus, the two most common, and also viruses. And treatment would be amoxicillin or augmentin, or Septin, or third generation cephalosporin.
Well, one thing to
Oh,
go to the next slide. Sorry, go to the next slide. So middle ear right here, guys. So fluid collection of the middle ear area, right? You can get outer ear infection too, like swimmer's ear, but we're going to focus on middle ear because that's where a lot of people come in with ear infection, right? So what CDC recommends is that, a lot of the time, middle ear infections can be because of viruses. So they usually recommend waiting to see 2 to 3 days will it go away. And then I'm also thinking about when the physician can do 2 different approaches: watchful waiting, coming back in 2 to 3 days, good fluid, rest, let pain relieve, let's see how it's going. And then if it doesn't get better, then we could prescribe antibiotic. Or sometimes you could give an antibiotic prescription and say, fill it in 3 days if it's not better. I kind of get nervous about, giving a prescription, fill it when it's not, even if I think, a lot of parents will go fill it and give it to them. So like watchful waiting and, just following up really closely. I like that approach, but, you have 2 different approaches. In this case, it's really, really important to talk to the parents and, about can be virus. Let's see if the patient gets better. Sinus infections, we see a ton of it. And most of the time, viruses are the most common causes of sinus infection. You have the normal sinuses, healthy, and then an inflamed sinus, and you have lots of fluid buildup. And when you have bacteria, what bacteria plays a big role in sinus infection? Again, strep pneumo. It's like the peep everywhere, strep pneumo, right? And then you get Haemophilus, Moraxella, occasionally Staph aureus too if you're colonized with it. So these are one most common causes of sinus infections.
And antibiotic treatment is usually only needed if the infection does not improve within 7 to 10 days. So, and generally, if a patient comes in, one of the questions we'll ask is, how long have you had this going on? And if they say it just started yesterday, then you can probably wait and not give any antibiotics. It'll probably resolve by itself. If it goes on for longer than 10 to 14 days, then we would consider taking an antibiotic. Severe pain, swelling in the front of the head, nasal discharge, high fever is present, and one of the things is if they lean forward and they feel kind of this fullness in their sinuses and in their face that's supposed to have some, and then these are indications that the bacterial infection is severe if they have especially fever, I would say. But you can't really tell, I don't think, by the color.
No.
Or
unless they're saying if you could start seeing blood in the mucus, then it might be. So I think giving it some time, so watchful waiting and then following up is going to be key. And then here's what CDC also recommends, right? We used to be for sinus infection, give 14 days, came down to 10 days. But now we know for sinus infection, 5 to 7 days is good enough.
And fluoroquinolones, have a lot of issues, and really about a quarter of all antibiotics given to people. So 25% of all antibiotics are a fluoroquinolone. But in these cases, if you can give something other than a fluoroquinolone.
Oh yeah, so amoxicillin, augmentin, ceftonir, and let's keep it 5 to 7 days and not 10 to 14 days. That's when we get into, other lectures we have given, and you always say, Dr. Horn, like, shorter, the better.
Shorter is better.
Yes,
right?
Yes.
Yeah, Brad Spellberg, I have to throw out his name. I like looking, he has a website, and on his website, Brad Spellberg, there's a shorter is better tab, and he goes through all the evidence and the randomized control trials showing that shorter courses are better. And it's not shorter is equal, it's shorter is better because you don't have all the issues with the antibiotics. You're not getting diarrhea, you're not getting all these problems with the antibiotics. And here we're going to have a little bit on bronchitis as well, because it's something that's frequently seen.
Yeah, so bronchitis, inflammation of the bronchi. And it's seen a lot. Number one cause of antibiotic prescription in the outpatient setting, right? Especially in the winter months when we have all the different types of viruses. This year we didn't because we all wore masks.
Yeah, that's right.
But when we have all these viruses, it causes inflammation in these small bronchial vessels, and then you could have purulence, mucus, right? But that doesn't mean it's bacteria. Is the next slide. You know, it doesn't mean it's bacteria. Most of the time it's virus, and occasionally it can be bacteria.
Bronchitis lasts less than 3 weeks, and so it's coughing, soreness in the chest, feeling tired, mild headaches, body ache, sore throat. And so if someone comes in and they have these symptoms, you know, really the goal of this is not to think, oh, they need an antibiotic, they need more and more antibiotics. Is it possible that they will get better without antibiotics? And most of these don't need antibiotics.
And the key is less than 3 weeks, you could have bronchitis symptoms. It could be up to 3 weeks. So, like, you know, us as physician calming ourselves down, it's still a virus.
Yes, right. And
yeah.
and also with pneumonia, after
Yeah.
they have a pneumonia, they're going to cough for a while. But it's normal to have a cough for several weeks and kind of cough all that stuff up, and they don't need another antibiotic.
We need to seek medical help when we have high fevers, cough with bloody mucus, shortness of breath, trouble breathing, symptoms more than 3 weeks, repeat episodes of bronchitis, then definitely, you know, see a clinician. And I like these CDC posters. You know, antibiotics treat strep throat, UTI, pneumonia. They don't treat most bronchitis, sinus infections, or ear infections.
Then we're going to have a little bit on procalcitonin. You know, I think procalcitonin is very good, and procalcitonin is really supposed to be very specific for bacterial infections. And so if they have a really high procalcitonin, do they have a bacterial infection? And if it's rising, it's a bad prognosis, bad prognostic indicator. If it's coming down, then that would be consistent with an infection that's being appropriately treated. And really, if they come in and you check a procalcitonin and it's low, you can still give antibiotics if you're really concerned about an infection. I wouldn't withhold antibiotics because the first procal is low in someone that you think has an infection. And if you recheck a procal the next day and it's low again, and you're already thinking about stopping antibiotics, that's really when to use how procalcitonin has been studied. With 2 low procalcitonins about 8 hours apart or so. And if you have 2 low procals and you're already thinking about stopping, that supports your decision to stop antibiotics.
Yeah. And then otherwise, 2 main conditions has been studied in pneumonia and sepsis, right? So if you are worried of, you know, in ER, we're seeing a lot of pneumonia cases. So this can be a tool if you have access to procalcitonin. And also ER, you're seeing a lot of sepsis cases. Again, if you're suspecting sepsis, just because your procal is low, you don't not treat. You treat and then you trend. So
Yep.
I always think of it as procal as a prognostic marker, and it is not diagnostic. But the most of the studies have been done in pneumonia and sepsis. Those are the 2 big things. And I think even recently they said, you know, sepsis and procal can reduce mortality if you use it the right way.
In comparison of biomarkers, so really, when we have procalcitonin here at the bottom, it's supposed to be the most specific marker we have for a bacterial infection. You know, there are other things like CRP, which is a marker of inflammation and not infection. And then fever, leukocytosis. These more things can cause, lots of things can cause fever and leukocytosis, but not a whole lot of things are supposed to be able to cause procalcitonin to become elevated. So it's quite specific. It has rapid induction, so it peaks in about 6 to 12 hours and correlates with severity of illness. So if it's extremely high, generally the patient is going to be a lot more sick with, they're sicker with higher procalcitonins. And okay, great. Any questions at all about any of the topics we discussed? We went through kind of a lot of topics, so if there are any questions on anything, please please ask us any questions you have. And I hope we've covered things that people are interested in. We cover questions. We get kind of we wanted to cover all the questions that we got from that we asked about. So if there's anything we didn't cover, feel free to email us and we can cover it in our next in a future topic.
So guys also gave us topics to cover. So this was one of the topics that we received, outpatient infections.
Yeah, sometimes we get kind of random questions here and there, and so we try to bundle them all up and have this as a bundle.
So if you guys have any questions or concerns, please let us know, and then we'll cover any other topics that you want. Thank you so much for joining us today.
Yeah, so we're not seeing any more questions. So thank you.
Have a
good day, everybody.